A very warm welcome to today's session on OSCE. Today's topic will be on lower GI bleeding and colorectal carcinoma. Okay, what are some of these colorectal conditions that we will encounter in our patients? This can be either tumor, which includes polyps and carcinomas. It can be bleeding due to diverticulosis, angiodysplasia, or colitis of various causes, infection, radiation, and inflammatory bowel disease. Obstruction is usually due to strictures or adhesions, and which can be acute or subacute, and also may be due to small or large bowel obstructions. I shall highlight the history taking in patients with abdominal conditions, gastrointestinal problems, especially the surgical ones, and also doing a proper examination. And popular OSCE stations will be the digital rectal examination, which I shall go through and show you a slide, and also the important investigation today, colonoscopy. You will be expected to know what is colonoscopy, what are its indications, and some complications. Okay, to start the session, we will go through a short clinical case of lower gastrointestinal case, and answer a few questions that are posed here. The patient is a 78-year-old man who was admitted for PR bleeding for 1 day. He passed a large quantity of bright red blood with clots. He felt dizzy and weak, but there's no history of pain or altered bowel habit. No previous history of blood-stained stools or melena, and there's no pain, abdominal pain or vomiting. He is a known case of hypertension and has suffered 2 strokes 2 years ago. He has suffered a stroke 2 years ago and is on Plavix 75 milligrams daily since then. And on examination, his BP is 100/60, slightly low, pulse rate of 100 per minute, slightly on the high side, and a poor volume, and a arterial saturation of 96%. The patient was alert and comfortable with mild pallor. Abdomen was soft and non-distended. There was mild tenderness and guiding in the left lower quadrant. Otherwise, the rest of the abdomen was normal and no masses were palpable. Rectal examination revealed a large amount of fresh blood and clots. No masses were felt, and proctoscopy was not useful due to poor visibility. Okay, so this is a short history and examination of a patient, elderly man with a massive hematemesis and tenderness and guiding in the left lower quadrant. What is the most likely clinical diagnosis? The answer will be bleeding diverticular disease. Second differential diagnosis will be a carcinoma of the colon, especially the sigmoid or descending colon. How will you assess the severity of the bleeding? Okay, is clinically the patient can be assessed by the amount of blood that he passes, the frequency, and the number of days he has been passing. And then by examination, the severity of anemia, how severe the anemia is, the BP and pulse. In this patient, he is mild to moderate bleeding because of the slightly low BP and a high pulse rate which is poor in volume. And we also make use of the Glasgow Blatchford and the Rockall scoring systems to assess the severity. Number 3, outline the principles of subsequent management of the patient. So this patient is a case of massive PR bleeding, so he must be resuscitated with IV fluids, blood taken for group and cross match, and maybe prepare for blood transfusion as well. As soon as the patient is stable, urgent colonoscopy should be done, after which the decision to operate or not depends on whether he stops bleeding or continues to bleed, and whether it's a mass or whatever the cause that you see on colonoscopy. Okay, the lower gastrointestinal symptoms are very important. Some of these common symptoms that we get is abdominal pain, distension, constipation, and or diarrhea, steatorrhea, melena, and hematochezia. Okay, so as far as the lower gastrointestinal symptoms is pain, abdominal distension, constipation, diarrhea, and hematochezia. Okay, these are the important signs or symptoms of lower GI problems. And this is classified with the acronyms Socrates, which refers to the site of the symptom, onset, character, radiation, associated symptoms, time course, exacerbating or relieving factors, and severity of the symptom. The other thing is, apart from localized symptoms of the bowel, you must also think of systemic symptoms of anorexia, weight loss, nausea, fatigue, which are often commonly seen in patients with malignant lesions such as colon cancers. Others like fever, itchiness, and confusion or jaundice may be related to the other organs in the abdomen, other solid organs of the gastrointestinal tract. Come to the location of the abdominal pain in patients with lower GI problems. The location of the patient's abdominal pain may help to narrow the differential diagnosis. So it's very important for you to get the exact location. Sometimes it may be necessary to ask the patient to point to the exact site of maximum pain in the abdomen. So in this respect, for lower gastrointestinal problems, the left iliac fossa and the suprapubic regions are the most commonly affected areas, okay, which are highlighted by the stars here. Okay, and I'm sure you're familiar with this diagram, the 9 regions of the abdomen. Okay, and today's lower GI problems mainly involve the left iliac fossa and hypogastric regions. Okay, and where the descending colon and sigmoid colon are located, and where most of the colonic problems originate or involve the descending colon and sigmoid colon and rectum. It must be not forgotten that the female patients in this area also the gynecological organs are there, the uterus, ovary, and fallopian tubes. Okay, now we come to the examination. Again, consists of 2 parts: general examination and local examination. General examination, which I already mentioned in the symptoms, the cachexia, loss of weight, marasmic or emaciated, okay, evidence of loss of weight, cervical lymphadenopathy, pallor, jaundice. These are all under general examinations. Very important to examine to get the signs. Local examination of the abdomen, and this must include the hernial orifices, include the careful inspection and palpation of the abdomen, especially the lower abdomen and the left iliac fossa. Okay. You must also familiarize yourself with the signs of intestinal obstruction, acute or chronic. Okay, the clinical features on inspection, palpation, percussion, and auscultation. And another important thing that you must be familiar, which is common in OSCE examinations, is the stoma. Okay, if the patient has a stoma, you must examine the stoma very thoroughly, according to standard protocol. Alright, so you must be familiar with how to examine the stoma. Next, another important OSCE interactive surgical OSCE station is a digital rectal examination, where you do demonstrate to the examiner how you perform a digital rectal examination. Proctoscopy is another important procedure that must be done, and of course the important sigmoidoscopy and the all important colonoscopy, which you must know what is colonoscopy, what are the indications, and what are the complications. Okay, like iliac fossa masses, the right iliac fossa, we will not go into them today, but the left iliac fossa, the important conditions that can present as a mass will be a diverticular problem, diverticular abscess, or mass. Okay, it can be a colonic mass or carcinoma, okay, especially descending colon or sigmocolon, okay, or rectal mass, higher rectal masses. These are the important intestinal problems that present in the lower left abdominal quadrant. Others include psoas abscess, left renal mass, bladder problems, left tubo-ovarian mass, and ectopic pregnancy. Okay, as for the investigations, the three main things which we do is blood, urine, which is not so important unless you're thinking of involvement of the urinary tract and bladder, such as a rectovesical fistula, okay, and also the other all important imaging, which consists of in abdominal problems. Abdominal X-ray is a very important component of investigation, and ultrasound. So abdominal X-ray and ultrasound become the preliminary investigations for almost all cases of lower abdominal problems. Next important is CT scan, especially the contrast CT scan, okay, contrast enhanced CT scan, colonoscopy, and barium enema, which is becoming less important these days because of the wide availability of colonoscopy. We shall now go through some practice OSCE stations related to the lower gastrointestinal tract, especially the colorectal region and lower abdomen. The first OSCE station is a patient, a 60-year-old man, complains of epigastric pain for 3 days. No vomiting of blood. He was mildly pale, and digital rectal examination shows the findings as in the picture. Question number 1. What is seen in the picture? Melanic stools on the glove finger. What are the possible causes of this finding? Upper GI bleeding, most likely a bleeding peptic ulcer or carcinoma of the stomach. What investigations will you do for this patient? I will do a OGDS or upper gastrointestinal endoscopy. The patient's HB is 5.6%, 6 grams per deciliter. Outline the management. The management includes adequate resuscitation with IV fluids and electrolytes and the transfusion of blood as the hemoglobin is very low, IV proton pump inhibitors, and H. pylori eradication medication. Question number 2. A 51-year-old man complained of weakness, lethargy, and dull pain in the right lower quadrant. Examination revealed a mass as shown in the right lower quadrant of the abdomen. Questions. What are the differential diagnoses? carcinoma of the cecum, appendicular mass, appendicular abscess, and Crohn's disease. Question number 2. What are the features of the mass you will use to determine and why? I will look for the consistency, hard mass, fixed or otherwise, irregularity of the border margins, and whether there's not tender or otherwise. Okay, these are features, if present, will suggest a highly suggestive of carcinoma of the cecum. What are the investigations you will do for the patient? A colonoscopy and a contrast enhanced CT scan. What are the complications of the mass? Obstruction, bleeding, and metastasis. Okay, these are the differential diagnosis of a patient with the right iliac fossa mass. The most common is appendicular mass or abscess, carcinoma of the cecum, and ascending colon. Occasionally, it can be due to a Schwab's abscess or a non-Hodgkin's lymphoma, and in children, intussusception. Ileocecal tuberculosis, which used to be common, is very rare these days. In fact, in some countries, it is more common to have Crohn's disease as a mass in the right iliac fossa. Okay, question or OSCE number 3 on surgical procedure. What is this procedure shown? The colonoscopy. Number 2, what are the indications for this procedure? PR bleeding, change of bowel habit, anemia, and screening procedure. What are some of the complications of the procedure? Bleeding, perforation, and oversedation. How will you prepare the patient for the procedure? You do a bowel preparation with fasting and oral administration of agents such as Fortran, Oroflate, or Picolex. And at the same time, the patient has kept near mouth and given a lot of oral fluids to take. Question number 4. This is a picture of a 62-year-old man who had a sigmoid colectomy done for colorectal cancer. He was told this is a temporary procedure. What is this structure? It's a colostomy, left iliac colostomy. What are the indications for the procedure? Carcinoma and diverticular disease or abscess. What are its complications? Gangrene, prolapse, retraction, and parastomal hernia. What would you advise the patient regards his diet? Advise to take a low fiber diet and decrease fluid intake so as to reduce the number of bowel movements. Okay, this is a difference to show you the difference between a ileostomy and a colostomy. Okay, ileostomy has got a spout about few centimeters long, which is placed inside the colostomy bag so as to prevent the secretions from causing skin damage around the stoma. Whereas a colostomy, it is flush with the surrounding skin because the stool is hard and it does not cause any skin problems. Okay, this is a colonoscopy image for question number 5 of a 28-year-old man with lower abdominal pain, tenesmus, and blood-stained stools for 3 months. Describe the findings. Okay, diffuse inflammation, mucosal inflammation with ulceration, bleeding, and slough with pus. Okay, diffuse inflammation, slough with ulcers. Okay, what are the possible differential diagnoses for this condition? It's a diffuse colitis, and the common causes are ulcerative colitis, infective colitis, radiation colitis, or corrosive colitis. How will you confirm the diagnosis? By doing a colonoscopy and biopsy of the lesion. Outline the treatment for the patient. His patients are given a course of amylosalicylic acid or 5-ASAS, sulfasalazine, analgesics, and some patients even need steroids to control the inflammation. Question number 6. These colonoscopic pictures are taken of a 42-year-old man with change of bowel habit. He has a strong family history of colon cancer. What is your diagnosis? Colonic polyps. Okay, these are polyps in the colon. Number 2, what is the significance of the strong family history of colon cancer? Okay, high risk for cancer. Once there's a family history, so these patients are also at a high risk for familial cancer. And he can be part of the familial adenomatous polyposis or FAP, where the patients have very high increased risk of colon cancer. What is the treatment for this patient? Polypectomy. Usually endoscopic polypectomy is the treatment of choice. What are the complications of this procedure? Of this condition? Bleeding, ulceration and bleeding is an important complication. Malignant change to become adenocarcinoma. Okay, these are the two common or dreaded complication of colonic polyps. Question number 7. A 70-year-old man presents with fresh, painless bleeding per rectum on defecation for 2 months. He also complains of a loss of weight and lethargy. Colonoscopy images are shown of the lesion shown is in the lesions are found in the sigmoid colon. What is your diagnosis? Carcinoma of the colon. What will be a biopsy? What histological features will the biopsy reveal? Adenocarcinoma, which account for more than 90% of colonic cancers. What is the surgical treatment of this condition? Sigmoid colectomy. How is the disease staged? It is staged by using the Duke's classification, Duke's A to D. Okay, here these are malignant ulcerative lesions or colifungating lesions here. You see, ulcerating and bleeding, irregular and angry looking, and these are the malignant lesions in the colon. Okay. Question number 8. This patient aged 40 years presented with abdominal pain of an on and off for past 1 month. Over the last 3 days, the pain was severe and associated with constipation, abdominal distension, and vomiting. He had an appendicectomy done 5 years ago. What do the X-rays show? Okay, the X-ray shows a distended bowel. Okay, and these distended loops of bowel are stacked one above the other, and they have got radio-opaque rugae that run throughout the width of the lumen of the bowel, and these are classically known as the valvulae conniventis, and these are signs of small bowel obstruction. Here it shows multiple air fluid levels located in the center of the abdomen, which are also indication of small bowel obstruction. What is your diagnosis? Small intestinal obstruction. He was treated with drip and suck regime. What is this regime? This regime consists of IV drip with electrolytes and using an NG, passing an NG tube to aspirate the stomach and decompress the stomach and the small intestine. What is the possible cause of this obstruction in this patient? Adhesions post appendicectomy. Okay, question number 9. The patient is a 74-year-old woman who complains of abdominal pain, constipation, diarrhea, and weight loss for 2 months. Over the last 5 days, she did not pass motion and she developed abdominal distension and vomiting. Describe the X-ray findings in this patient. Okay, it shows a dilated colon from the sigmoid to the cecum, ascending colon, okay, and right until the cecum. So there's a diffuse distension of the large intestine from sigmoid proximally. Small bowel appears to be not visualized. They seem to be normal. What other investigations will you do for the patient? Flexible sigmoidoscopy, and if possible a colonoscopy, and if that is not possible, then a barium enema or a contrast enhanced CT scan. What is the possible diagnosis in this patient? Carcinoma rectosigmoid with acute intestinal obstruction. Outline the treatment for the patient. Patient is put on a drip and suction and nasogastric tube. Antibiotics are administered, electrolytes are corrected, and patient planned for sigmoid colectomy. Okay. Okay. These X-rays show you the features of small bowel obstruction. Small bowels are usually distended and occupy the center of the abdomen, and they usually have, on erect view, they also have multiple air fluid levels. Anything more than 5 levels is significant of obstruction. And this distended small bowel have got valvulae conniventes, okay, which run through the whole width of the dilated small bowel. And air fluids levels are seen on erect view. Whereas this patient, this X-ray show large bowel obstruction, where the distended large bowel occupies the periphery of the abdomen. It runs along the periphery, right side, left side, and the transverse colon. All right, and they are much bigger, distended, and then they also have these mucosal folds known as ostrations, but these ostrations are incomplete. They run and stop here, and then another one comes from the other side. So incomplete mucosal folds known as colonic ostrations. Okay, and they're large size. So peripheral location, ostrations, large size. It means indication of large bowel obstruction. Okay, this slide shows you the role of use of CT scan in intestinal obstruction. Okay, all the while classically plain X-ray of the abdomen was the main diagnostic tool that we have. But now CT scan, contrast enhanced CT scan, have become a very important. These are CT scans showing you a distended large bowel here with air fluid. Okay, and then the CT scan, it can detect the presence and the site of obstruction. Okay, here it is in a sigmoid colon here. So it can detect the site and location of the obstruction. Okay, it can also state distended bowel. In the next slide I'll show you. It can tell you the status of the wall of the distended bowel. Then if there's perforation, it can also detect free air and the site of perforation. It can also give you information about the vascular status of the by using contrast. You can get a picture of the vascular status of the distended bowel, whether it is ischemic or whether it's going to be strangulated. And then the cause also can determine in a lot of cases. Those who are very experienced in diagnosing, they can detect whether there's presence of a cancer, a mass, or congenital bands, adhesive bands, and also it can give you information about the stage of the cancer, if it is a cancer, okay, and also lymph nodal status. Okay, in this case, this is a contrast CT dilated loop up to the distal colon. Okay, here this sigmoid colon is okay, is until the distal colon here. All right, and in this next picture you can. Okay, now there are two cases of surgical resections in colon cancer. Okay, so what type? The first one, what type of colonic resection is this? Where the cecum, the appendix, ascending colon is resected right at the junction of the right 1/3 and left 2/3 of the transverse colon here. This whole thing is removed. And what type of resection is this? And this is known as the right hemicolectomy. Okay, where the whole thing is here. What is the indications for this resection? Carcinoma of the cecum and the ascending colon. Carcinoma of the cecum and ascending colon, you go for a right hemicolectomy. What are the arteries that you ligate in this resection? Okay, you ligate the ileocholic artery, the right cholic artery, and the left branch of your middle cholic artery. Okay, ileocholic artery, right cholic artery, right branch of your middle cholic artery. Okay, what type of resection is this? Okay, this is known as where the sigmoid is removed, so this is known as a sigmoid colectomy. Okay, where the whole sigmoid is removed here. What is the indication for this resection? Carcinoma of the sigmoid colon and complicated diverticulosis of the sigmoid colon, such as bleeding or perforation. What arteries are ligated in this resection? Okay, here sigmoid arteries here. These are the sigmoid arteries. One artery gives you number of branches, 4 or 5 branches here. They are all ligated. And also the descending branch of your left cholic artery here. So these are the arteries related.
Colorectal or PR examination is an important part of a general surgical, abdominal, and urological examination, and is indicated in patients with change in bowel habit, pruritus ani, tenesmus, PR bleeding, and also prostatic symptoms. Given its importance and frequency of being performed, it's vital that medical students and junior doctors are confident and competent in performing this essential examination. And by the end of this video, that's exactly how you should feel. In medical school exams, you may be expected to perform a colorectal examination on a mannequin, as opposed to a real patient. However, the process and steps you need to perform will remain the same regardless of the scenario. The basic equipment we need when performing colorectal examinations include non-sterile gloves, some gauze or paper tissues, and some lubricating gel. After washing our hands, we introduce ourselves to the patient, clarify their identity, explain what the examination involves and why it's being performed, and then gain their verbal consent. Given the nature of the examination, it's important that we also have a chaperone present, and they should also be introduced to the patient. We then position the patient on their left-hand side with their knees bent towards their chest. and we uncover the patient from their waist down to their knees. Next, we put on our gloves. And then inspect the perianal area and the anus. This will require us to gently part the buttocks or softly lift the left buttock so that the perianal region is fully visible. It's important to ensure that we have a good light source for when we inspect this region. During our inspection, we are looking for various abnormalities, including rashes, skin tags, excoriations, anal fissures, fistulous openings, anal warts, perianal abscesses, external hemorrhoids, fecal soiling, mucus or bleeding. We then ask the patient to bear down or strain and examine for any external projection of mucosa, which would indicate the presence of rectal prolapse. Next, we use lubricating gel to lubricate the gloved index finger of the right hand, and slowly and gently insert the pulp of the index finger into the anus along the midline. We ask the patient to clench our finger with their anal sphincter to assess the sphincteric tone. With the finger not fully inserted, we then rotate the finger to perform 360-degree sweeps to assess for any wall thickenings or irregularities. Then, we fully insert the finger into the rectum as far as it can be comfortably introduced. And again, we slowly rotate the finger in 360-degree sweeping motions. Whilst examining the rectum, we should be noting any thickening or irregularities of the wall, any tenderness, or the presence of any feces and its consistency. Next, in a male patient, we want to palpate the prostate gland, which will be located at the anterior wall of the rectum. A normal prostate should feel smooth in texture, have 2 lobes and a palpable central sulcus, and measure between 2 to 3 centimeters in diameter. We then gently remove our finger and inspect the glove for the presence of any feces, blood, or mucus. We clean any feces or gel from the nasal cleft and tell the patient that the examination is complete, before thanking them and asking them to redress. We can then document our findings, or, if in an exam scenario, we'd report our findings to the examiner, making sure to describe the exact nature and location of any external or internal irregularities using a clock face system, with the 12 o'clock position representing the anterior part of the rectum at the perineum.
Okay, thank you for joining me for this session on OSCE on carcinoma of the colon.